Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms. Marcus at Home welcomes Dr. Alan Lee Hinderliter in Durham, North Carolina, with whom we would like to discuss, based upon his recent TRIUMPH study, the impact of non-pharmacological or lifestyle intervention in people with resistant hypertension. Alan, it's a privilege and an honor for us to have you today. Thanks for being with us.
Thanks very much for the invitation. I really appreciate it.
Dr. Hinderliter is a cardiologist. He is associate professor at the University of North Carolina at Chapel Hill, and his major foci of clinical and academic work are echocardiography and hypertension, where he has published many papers in the last years, including a very recent JAMA review paper and surely the TRIUMPH study, which is one of the very few studies that tested in a randomized way non-pharmacological interventions in people with resistant hypertension. My co-moderators today are Dr. Julian Weinmann-Menke, who is professor of nephrology at the Johannes Gutenberg University in Mainz, Germany, and Florian Custodis, who is head of the Department of Cardiology in Saarbrücken, Germany, and who does academic work at the Saarland University Medical Center. My name is Gunnar Heine. I do nephrology in Frankfurt, Germany.
So, Dr. Hinderliter, it's really great to have you here and to discuss this really fascinating study. So let's start. Fascinating, I think it's because on one hand, those patients are common in our clinical practice and treatment is really demanding. And on the other hand, we have no reasonable data on the effects of physical activity. And last but not least, lifestyle interventions and clinical trials are really challenging. And I think because this is a great study. Before we start, could you just, for our viewers, just introduce and give us your definition of resistant hypertension you used for your study?
We defined resistant hypertension as blood pressure that was still higher than desired after treatment with at least 3 antihypertensive medications, one of which had to be a diuretic, as long as diuretics were tolerated. And we actually modified the definition slightly with the publication of the ACC-AHA guidelines here in the US in 2017, which, as you know, redefined hypertension as a systolic blood pressure of over 130 or diastolic blood pressure over 80. We focused on systolic blood pressure, but initially with a threshold of 140 millimeter mercury, and then after institution of the new guidelines or publication of the new guidelines, we moved that threshold down to 130 millimeter mercury. So folks had to be on 3 medicines and have a systolic blood pressure that exceeded 130 or require more than 3 medications to achieve that goal.
Mm-hmm. Okay. And could you just briefly introduce our viewers to your personal motivation and the background, the question of the study?
Certainly. The personal motivation is that I work in a hypertension clinic here at the University of North Carolina, and we see a lot of patients with resistant hypertension. That's the primary reason for referral to our clinic. And we certainly have very good medications for treatment of hypertension, but some folks just don't respond as well as we would like. And we're often at wit's end about what to do next. And it's been my observation that many clinicians, I think including myself, really put a heavy emphasis on lifestyle modification in patients who have modest blood pressure elevations, and we may want to avoid using medications, and those patients often want to avoid taking medications. So in folks with modest blood pressure elevations, lifestyle interventions are really emphasized by clinicians, I think. Once we get people on medications, and particularly 3 or 4 medicines or even more, there's more of a focus, I think, on adjusting those medications and treating with drugs. And lifestyle modifications sort of take a backseat. So the question we had is really, how important is lifestyle modification in these folks? Can we accomplish or achieve a lot of blood pressure reduction with an intensive lifestyle modification program? And does lifestyle modification really have an important role in these folks with resistant hypertension? In our view, even though all of our guidelines recommend lifestyle modification in these folks, it wasn't entirely clear cut to us that the benefits would be the same as they are in folks who have modest blood pressure elevations or who may only take a medication or two. So it wasn't clear to us that these folks who are resistant to medical therapy would in fact benefit a lot from lifestyle modification. So that's what motivated this study.
Okay.
And we had done previous studies in folks who weren't on medications and saw a very satisfying, gratifying response. But there really wasn't much in the literature at all about lifestyle modification in these folks with resistant hypertension.
Okay. And what kind of methods did you use? What endpoints did you define to check that out?
Well, our primary endpoint was blood pressure, measured in the clinic, in the research clinic, with a very rigorous protocol. And we also put a heavy emphasis on ambulatory blood pressure monitoring. So patients, or excuse me, participants in the study had blood pressure measured very carefully in the research clinic before and after the intervention, and had ambulatory blood pressure monitored before and after the intervention. We looked at, those were the primary endpoints we were interested in. We looked at some other markers, if you will, of cardiovascular risk that we thought might be modified. So things like baroreflex sensitivity, heart rate variability, flow-mediated dilation of the brachial artery, a measure of endothelial function, left ventricular mass by echocardiography. But the primary emphasis really was on what the intervention did with blood pressure. And the intervention arm included 3 times weekly visits to a cardiac rehabilitation program. We wanted to structure this in a way that really could be implemented in a larger scale. So we piggybacked it onto cardiac rehabilitation programs, and cardiac rehab programs here in the US put a heavy emphasis on structured exercise, and we supplemented that with behavioral modification to help patients lose weight, and a lot of instruction on dietary measures to lower their blood pressure, particularly sodium restriction and institution of the DASH diet or DASH eating plan. So that was our active intervention. Our control group also had an intervention. They spent an hour with a health educator who taught them basically the same techniques and recommended the same interventions that the folks with the more active intervention got. And they spent an hour with the health educator, had an individualized lifestyle modification plan developed, but then were on their own to institute it.
Okay. What I like about the study is this broad panel of methods and surrogate markers like FMD and pulse wave velocity. And so could you introduce us and our viewers to the results?
Sure.
I'm really curious, and they might be really curious what the effects have been.
Well, one thing that we looked at was weight, and our subjects in the active intervention group lost about 15 pounds. Interestingly, those in the control group also had a significant amount of weight loss, about 8 pounds, a little over 8 pounds on average, which told us that we really enrolled a very motivated group of patients. So even our control group actually had, in some very objective ways, a nice response. But our primary interest again was in blood pressure, and systolic blood pressure was decreased by over 12 millimeters mercury in our active intervention group. And that, as you know, is what you might expect with a couple of antihypertensive agents. This was a clinic systolic blood pressure, and our control group actually had a decrease of about 7 millimeters mercury, again reflecting the fact that they were a motivated group of people and did a lot on their own to improve their lifestyle and to lower their blood pressure. We also put a big emphasis on ambulatory blood pressure as an endpoint, and in many ways that's a superior endpoint to the clinic blood pressure. And the folks in the active intervention had a decrease of about 7 millimeters mercury in ambulatory blood pressure, systolic blood pressure, and really no change observed in the control group on ambulatory blood pressure. So a very satisfying response, I think, compared against an active control. This more intensive intervention really resulted in a blood pressure reduction that you might expect with 1 or 2 medications.
What I noticed reading your trial cohort section, you included nearly 50% female patients and 50% non-white patients, which is really a diverse cohort and which reflects clinical reality, which I think it's really reasonable to do, and most clinical trials show us another reality in terms like that, and that's what I noticed about the cohort.
Yes, we were very pleased by that. The gender split was basically 50-50, and we had a broad racial representation in the study cohort. And that's particularly important in the southeastern United States, where high blood pressure is a very significant problem for the Black community.
I don't know if I got you right. Could you just dive into those effects on FMD and arterial stiffness? What did you find in terms of those markers?
Well, we measured flow-mediated dilation of the brachial artery as a measure of endothelial function, and we found a greater improvement in that measure of vascular function of endothelial health in the folks who were in the active intervention. Much to my disappointment, because I spent many hours in a dark room measuring echocardiograms, we really didn't see a change in left ventricular mass. It could be that 4 months just wasn't long enough to see that, and we actually have some 1-year data that we've collected and are analyzing now, and we'll see if the answers are different at 1 year. But we actually didn't see a change in LV mass. In contrast to some of the studies that we've done in folks with untreated hypertension, where we did see a change in LV mass, nor did we see a change in vascular stiffness. Okay. But there certainly was a benefit in flow-mediated dilation, which we think is also an important endpoint.
Actually, it's an interesting point where we are at the moment, because one of my questions when I read the manuscript was, do you have a follow-up of these patients? Because I think there were 4 months really like tight, like 3 times a week they come to a training, had like teaching, and were used to like their training courses. But what happened after the 4 months? I mean, then you stopped it, I guess, and then the patients, they should do it on their own, or what? How was it planned?
Yes, that's true. We didn't really have, and I think that will be a very important part of our study in the long run. We didn't really have an active follow-up intervention of any sort. There was a lot of emphasis in the training in the active intervention group on developing life skills that could be maintained in the long run. So that was a very heavy emphasis. But as you know, at least in weight loss studies, one of the real problems is that once the trial is over, the weight goes back up, and it will be interesting to see what happens with our folks. One bit of an issue is that you've probably heard a pandemic happened, and that compromised our ability to get some of the follow-up data that we wanted to acquire. But still, we have a lot of data, and I think it'll be interesting to see how well patients maintained their healthy lifestyles or their lifestyle interventions, and how well the blood pressure lowering persisted.
And actually, maybe more a suggestion. Do you thought about like a web-based training concept? Because we actually started here in Germany a web-based training where we like connect with the patient only once in person at the beginning, and then actually we track them and talk to them via the internet, and also have every week a new training plan for them. So they do not come to the hospital or to a training unit. They really have only contact via the internet. And interestingly, this works. Yeah. So the patients are pretty like, excited about this, because they do not have to go back and forth. And this you can do over a longer time, I think, and not like only like a limited time, only for as a suggestion, I think.
Yes, no, yeah. I think that's a great direction to take this kind of research, to see how well similar goals can be accomplished without in-person participation in the exercise program. And I must say, our intervention really was obviously based on an in-person participation, and the sort of group dynamic for both the exercise and the educational sessions, behavioral modification, was considered really helpful by our collaborators, who were largely behavioral medicine folks. But I think really working to accomplish the same sort of thing without inpatient or without in-person participation is an important endeavor, and could certainly make this sort of intervention more applicable to a large group of folks. I think, speaking of that pandemic, it has made us all, a little more comfortable with long distance forms of communications and interventions.
Yeah, that's for sure.
Yeah.
And actually, I have another question for the inclusion criteria, because the definition of the resistant hypertension you explained at the beginning, but I saw in the manuscript you did not measure like levels of antihypertensive medications. So maybe these patients really took their medication after starting the study, and this in both groups, because I think it's interesting that also the not intense group is losing so much weight and it's getting a better blood pressure. I mean, that's impressive. Yeah, that's
Yes, no, I think that's a very fair criticism, and I think one of the limitations of the study. We did try to use some tools to look at adherence, and in fact disqualified subjects who appeared not to be adherent. We use the MEMS method on pill containers to see if they at least opened their pill containers. Obviously, they took their medicines, but we use that technique and some questionnaires to get at medication adherence. But as you know, those are far from perfect. And I think I do think that's a very legitimate criticism of the study. When I think there's much greater appreciation on my part and on the part of most folks who deal with hypertension about how important an issue adherence is now than there was, 7 or 8 years ago when we were designing the study. We all had the sense that some of our patients don't take their medications as well as they should. But with the development of assays to look at blood and urine levels, I think we've become much more aware that that's really, really a serious issue. So you're absolutely right. I wish we had that sort of data.
Yeah. Maybe in a further study.
Yes.
Yeah.
So I would have actually one last question. You included patients who did not have secondary hypertension according to the treating physicians who sent the patients to your center, but there were some people who had rather high aldosterone, and around about 1/3 of patients were on spironolactone or eplerenone. Did you check whether these patients who either had the medication or those with very high aldosterone did have another response to your intervention? Did they have a higher or less impressive drop in blood pressure?
We've not looked at that. It's a great idea. Thank you for the suggestion. I think now compared to 7 or 8 years ago when we designed the study, we're also much more aware of what an important role unregulated aldosterone production plays in the pathogenesis of hypertension. And certainly we appreciated back then the fact that primary hyperaldosteronism was a common problem in folks with resistant hypertension, but it's much clearer now that it's a big issue, and our criteria for making that diagnosis have really morphed over the last 7 or 8 years. So that's a great suggestion, and we will take a look at that.
Maybe I finish with one very last question, because surely the dietary approaches are clear. We recommend to the people to take as few sodium as possible and as many fruits and vegetables as possible. It's more difficult, I guess, with a physical exercise, and not everybody can come to these centers. So what do you recommend to your patients who see you as a regular patient, who are not in a clinical study? Which kind of exercise do you recommend to them, and how often should they perform this exercise?
I think it's important for patients to find a form of exercise that they like. So we generally recommend to shoot for at least 5 days a week, doing 30 minutes of moderate or vigorous physical exertion. A brisk walk is a great form of exercise. Running and swimming are great forms of exercise. Elliptical machines and the like are great forms of exercise. But I think an important point is that patients should find a kind of exercise that they really enjoy.
So thanks a lot. It was a
Thank
pleasure
you.
talking to you. We are looking forward to reading the long-term data. Maybe we
Okay.
meet once again in 1 year or so.
Sounds
And until
good.
then, have a nice winter time in
Thank you.
North Carolina. Have a nice Christmas season, surely. And
Yes.
see you hopefully one day again. Thanks for being with us, Alan.
Thanks very much
Bye.
for the invitation.